Everybody, my name is Danielle Deptuck, and I am the support facilitator at the Self-Management Program of Southeastern Ontario. We would like to welcome you to the fifth of our series of Lunch and Learn webinars for healthcare professionals as part of our efforts to build various communities of practice in the region. I just have a few housekeeping pieces to mention before we begin. As you will notice, you are all currently on a muted state. In just a moment, I will unmute everyone. So if someone is on the phone but for some reason cannot access the webinar, please speak up at that time and I'll take down your information in order to troubleshoot with you offline once we get going. Then before the beginning again, I will mute everyone just so we don't hear your background noise. If you have any issues during the webinar, please get my attention by virtually raising your hand. So there's a little hand icon on the webinar screen, and if you click on that, it'll get my attention. Or the other thing you can do is go into the chat area in the chat box and type in whatever you're trying to tell me there as well. And so now I'm about to unmute everybody. Let's see here. So do any of our participants have any technical issues that you need to make me aware of? Now would be the time to do so. Okay, so if you're on the phone and for some reason unable to connect online or even speak to me, feel free to contact me at the email address that would be in your reminder email, which is selfmanagement@kchc.ca, and that's all lowercase, one word. And I'll be checking my emails as we go through so that I can troubleshoot offline with anyone having problems. So just so you know, we will be answering questions at the end of the webinar, but please feel free if you think you might forget them or you want to keep track as you're going. You can type your question ahead of time as you think of them in that chat box that I mentioned earlier. And then what we'll do is at the end, I will make sure that our presenter knows that I've got some questions for them, and I will read them out loud and unmute the person who asked the question so there could be a bit of a dialogue. And if it's decided that we should have a bigger discussion with the whole group, I can unmute everybody at that time as well. If you would like a printout of the slides with spaces for notes that will be used, it can be downloaded from our website. And again, the direct link to that was in your reminder email. There were also some other documents related to the webinar that are available there for you to view online or to download and print. Lastly, we would like to mention that we have an upcoming Choices and Changes workshop next Friday in Picton. Feel free to refer any of your colleagues that you think that might be interested in attending that workshop, and then they could also attend these webinars going forward. Or if you're attending this webinar and have yet to take Choices and Changes yourself, we highly recommend that you attend one, either next Friday's workshop or the next one that you can fit into your schedule. So our calendar tool on our website, livingwellsoutheastontario.ca, lists all of these workshops, and I'll also provide a link to our calendar in tomorrow's follow-up email that will be sent to you. Now I would like to present our speaker for our fifth webinar called Diabetes and Smoking Cessation, Self-Management and Success. Karen White is a registered nurse who has worked in primary care for about 20 years. She's also a certified diabetes educator, a smoking cessation counselor certified with TEACH, and a chronic disease prevention and management nurse at Belleville Quinte West Community Health Center. She loves to see clients' patients learn more to prevent and self-manage their chronic conditions in their own lives. So now I'm going to pass on the screen to Karen, so it'll be just a moment, and then she'll shortly go on. And let me just make sure that Karen is also unmuted. I just realized she might not be. All right, Karen, you should be good to go.
Okay. Hi there, and thanks for joining us today on Halloween Day to talk about diabetes and smoking cessation. Let me start off by saying that I don't consider myself an expert in the combined topic, but as I get excited when I have an opportunity, and each opportunity we have to help our clients or our patients, whatever we call them, to be in the best health possible. My role at the center is chronic disease prevention and management nurse, and I'm really glad that that word prevention is in my title. I have talked with many of my counterparts, and they're actually chronic disease management. I love to think that the interaction that I have with the people that I see on a daily basis can help them either prevent a chronic disease from developing or at least can prevent some of the complications of those chronic diseases. So that's where my interest in this topic is. A few years ago, I did really push to get smoking cessation as part of our program that we would offer here, knowing that there is probably not one chronic disease that could not be improved if people did stop smoking. So today, what I really want to do is probably review a lot of things a lot of you are already aware of. We'll go over summarizing the complications of diabetes itself, also summarizing the complications of smoking, and then hopefully we'll be able to understand the relationship between diabetes and smoking. And lastly, I hope we'll be motivated to encourage smoking cessation amongst all our patients, whether they have diabetes or not. It's interesting to note that I just returned from the Vascular 2013 conference a couple of weeks ago. That was a conference with vascular, cardiac, stroke, and diabetes. And walking through that whole place, I only saw one poster that related to smoking and the effect that it has on so much of our health. I was amazed at that we don't have more emphasis on the effects of smoking or smoking cessation. Diabetes itself, one of the recent facts that I had just taken down is that it's the 6th leading cause of death in the USA. Treating the complications of diabetes takes $1 out of every $10 spent in healthcare every year. I just was looking through the autumn 2013 Diabetes Care magazine today, and one of the articles in there, the author who herself has diabetes made the comment that people with diabetes incur medical costs that are 2 to 3 times higher than those without diabetes. So we certainly are looking not just from the physical point of view, but also from the financial, economical point of view of what diabetes and then smoking can have on our health. So just in review for most of you, just looking at the complications of diabetes. High blood glucose levels certainly can cause a variety of costly and potentially life-threatening complications. Heart disease is one of them. People with diabetes are at a very high risk of heart disease and stroke. In fact, approximately 10% of acute hospital admissions are related to diabetes and its secondary complications. And up to 80% of people with diabetes will die as a result of a heart attack or stroke. Kidney disease is another one of the complications that we look at. And high blood glucose levels, high blood pressure can certainly damage the kidneys and prevent them from functioning properly. About 1/3 of the people who have had diabetes for more than 15 years will develop kidney disease. Eye disease, or the diabetic retinopathy that we look at, it's estimated that approximately 2 million individuals in Canada have some form of diabetic retinopathy. This effect of diabetes on the eyes is actually the most common cause of blindness in people aged 65 years and younger, and the most common cause of new blindness in North America. Nerve damage. Diabetes affects circulation and immune systems, and that in turn impairs the body's ability to heal itself. As a result, people with diabetes are less likely to feel a foot injury, such as a blister or a cut. And if that's left unnoticed and untreated, even small foot injuries can quickly become infected and lead to potentially serious complications, such as amputation. It's interesting to note that 7 of 10 non-traumatic limb amputations are the result of diabetes complications. Depression. Depression is approximately 25% of people with diabetes do suffer from depression, either at the time of diagnosis, when they first get that diagnosis, or as they develop through the time period, sometimes because they cannot control their sugar, sometimes because they just have not received proper coaching and the ability to learn how to manage their disease. And that's where we've had all the effective self-management programs. We've just finished the self-management living with diabetes. And it's amazing the results when we see those come back in as a diabetic educator. When I see those people come back to me, it's amazing the effect that a program like that can have on the depression that you see amongst the people with diabetes. Changing the fact then to the other side and looking at some fast tobacco facts. 17.5% of Canadians 15 years and over currently smoke. We had done a little quick study in our session when we did, or in our clinic here when we started the program for smoking cessation, and we were expecting that we would maybe see 10% of our clients aged, we did a 16 and over, currently smoke, and we actually are sitting around 20%. So that certainly is even though that's a statistic from 2010, it's probably very accurate even for today. 90% of people who smoke become addicted before the age of 18. And tobacco-related disease counts for at least 500,000 hospital days each year in Ontario alone. Those are facts that certainly had to do with why I was actively pursuing a smoking cessation program at our center last year. Let's just look at some of the complications of smoking. Most people know that smoking can cause lung cancer or other respiratory problems, or it can certainly aggravate them if they're already there, but it also causes a lot of other illnesses. Smokers actually take 25% more sick days than non-smokers in a year. Smoking decreases the amount of oxygen reaching the tissues of the body, and this increases the risk for heart attack and stroke to the rate that it's actually 2 to 3 times higher incidence of death for people that are smoking. Smokers tend to develop coronary thrombosis 10 years earlier than non-smokers and make up about 9 out of 10 heart bypass patients. In fact, cardiovascular disease is actually recorded as the main cause of death due to smoking. It even is higher than lung cancer, apparently. Smoking increases blood pressure by releasing adrenaline, which causes blood vessels to constrict and the heart to beat faster. Smoking also slows the circulation in the smaller blood vessels, and nerve damage may reduce sensation. An article in Diabetes Care, an older volume of it, identified a couple of studies that actually examined the relationship between cigarette smoking and neuropathy in insulin-dependent people. One of those studies indicated that adolescent smokers were more likely to report neuropathy symptoms than non-smokers. It's interesting in that I just, in the last 2 weeks, saw a young type 1 diabetic, 21, 22 years of age, that has had diabetes for about 10 years and has actually been unable to work and maintain a job because of the neuropathy in his feet. Here's somebody that fits into that category right away. The neuropathy started as a teenager in interfering with his ability to work now. Smoking has been identified as a risk factor for insulin resistance. And a number of studies that are looking between the association between smoking and the incidence of glucose abnormalities. These studies actually can identify either prediabetes, type 2 diabetes, actually to the point where they're indicating that smoking can lead to the development of type 2 diabetes. It's actually believed that catecholamines, a type of hormone, are produced in greater quantity in smokers and act as an antagonist to the insulin action. People with insulin resistance, whether they are ones we're seeing for diabetes alone or whether they are people that have not yet developed diabetes, can't properly use their insulin. And that does certainly add to the fact that there seems to be a real relationship between insulin resistance and smoking. So if we put diabetes and smoking together, I don't know if you noticed the similarity that I did, but there certainly was a lot of those same similarities that we identify as complications of diabetes also were complications of smoking. The same things were listed on both columns there. Each year, more than 45,000 Canadians die of smoking-related illnesses, and people with diabetes face an even greater risk from smoking. Just like blood pressure or high glucose levels, the poisonous chemicals in cigarette smoke attack the blood vessels. And this contributes to the hardening of the arteries, impairs the blood's ability to carry oxygen throughout the body. Smoking has also been shown to deteriorate glucose metabolism and can lead to type 2 diabetes, as I've already said. We're going to look at a few items of interest from some of the studies that were mentioned and some of the studies that have shown the combination of those two together. First of all, just looking at the combined. Together, the deadly combination of high blood glucose and smoking dramatically increases damage to blood vessels that feed the heart, the brain, the eyes, the kidney, and peripheral nerves, speeding up the long-term complications of diabetes. So, smoking can increase the possibility of a diagnosis of diabetes, and on the other hand, smoking increases the risk of diabetes complications. Do we really need to go further to know that we should be talking about smoking cessation with our patients, with our clients that have diabetes? Well, I mentioned some of those studies. There was a systematic review of 25 studies that found all but one of those studies, so in 24 studies, revealed an association between active smoking and an increased risk of developing diabetes. On the basis of this review, it's actually estimated that 12% of all type 2 diabetes in the United States, and Canada wouldn't be far behind, may be attributed to smoking. There was actually one study performed at the California State Polytechnic University in 2011. It was also a similar study was done in Australia. The study in California actually was looking at rats, and it was done from a science point of view as much as it was done from a medical point of view. But the people in that study actually injected nicotine into rats. The rats, some of them had diabetes and some did not, but they found in all of the rats their A1C was increased. And the study that was done in Australia, they actually looked at 34 people who did smoke, 34 people who had diabetes, and 34 people who did not have diabetes. All 75 of them were smokers, or however many that is, 34 and 34, 68. All of them were smokers. And again, they found in all of those people the A1C increased proportionately to the amount of cigarettes that they smoked. What's interesting in that same study, this same type 1 patient that I had seen with diabetes in the last couple of weeks, as I said, had the neuropathy. He had stopped smoking about 6 months ago. And in the last 6 months, since he stopped smoking, he has actually reduced his NPH insulin by 6 units. For a type 1 diabetic, he was only taking a small amount of the NPH insulin, and to reduce it by 6 units daily is a large amount for him. Again, supporting the fact that nicotine can raise an A1C and can raise sugars. So, smoking cessation, how and when should we consider talking about it with our clients? Smoking is a chronic addiction, and it may require repeated interventions over many years. But we can be optimistic. The cumulative effect of simply asking about interest in stopping and then offering to help is significant. My thought would be we should be offering this at every visit. We bring them in, if they come in for primary care and they're going to see the nurse practitioner or the doctor, we bring them in, and at every visit we seem to do a blood pressure or temperature. I think we should be starting that we're asking what their status is on their smoking cessation. Are they still smoking? Have they considered stopping? It should be something that is just built right into that process. The other thing that I think is really important, and as a smoking cessation counselor, I'm putting an alert right into the chart when they demonstrate to me that they have quit. I'm not waiting 6 months to put it in. If they come in and say, I had my last cigarette 3 days ago, I'm putting it right into the chart now, so that when they do come in, I'm encouraging our staff to look at that and not only say, ask the question about smoking, but I see that you stopped smoking 2 weeks ago. How's that going for you? Well, congratulations for not having any more cigarettes. If we can reinforce that, I think there's a real benefit to the clients too. It's interesting to note that how little time can mean a big difference. And those of you that have seen gone through the choices and changes, we use this sort of information as well in that choices and changes program. But 1 to 3 minutes can improve if that thought is just mentioned, as I said, just briefly, and we can go through this whole chart of how much it can increase if we just mention that to the clients. Sometimes it may seem like we're rehashing something and getting them frustrated, but we don't have to make it invasive. We just, are you still smoking? Have we had an opportunity to talk to you about the concerns we have with your smoking habits? And certainly the more time we can take, the better it is. Everybody that's referred to me for smoking cessation doesn't necessarily even enter the program at that point, but they are referred. We can talk about it. We talk about their options and where they can go. And sometimes then we fall into that optimal intervention time of having 10, 15, 20, sometimes 30 minutes to talk to them about it. One of the things that I did put this in one of the handouts. It's available on the Canadian Diabetes Association site, and it's your diabetes focus visit. So as a diabetes educator, I certainly have things that I am preparing the client that we're going to be talking about if they come back to see me. One of the things that's on there is that having a conversation with them about exercise, food choices, smoking, mood, sexual function. And I wonder how many of us talk about food choices and talk about exercise, and we don't even touch on some of those other, the smoking, the mood, the sexual function. We're just happy to talk about the lifestyle changes that in nutrition and in exercise, but it's really important that they know that we will be talking to them about smoking. And really that question about smoking can be just as valuable as the food choices and the exercise. I provided a variety of tools. As Danielle had mentioned, I was trained through the TEACH program and associated now with the Center for Addiction and Mental Health. There are several smoking cessation programs, the Ottawa model, the QUIT program, the TEACH. All of them are beneficial. I just had the opportunity of taking the teach at the time I was getting the program in, and that's where I did get my training. And these next few slides are available from them. They are copyrighted of their possessions, really, copyrighted from their program. Recognizing that smoking cessation offers dramatic health benefits for our clients, and it's interesting to highlight how quickly some of those benefits can happen. The motivation of those to quit really doesn't predict the response to the treatment. It's important that they do have some motivation, but that can be increased when effective treatment is offered. I often tell the people that the Weight Watcher program, it's not the recipes that they offer that's most effective. Sometimes it's that accountability, that effective thought of coming in and being weighed. And sometimes the motivation for smoking can be really reinforced with coming back in and talking to a counselor, talking about the barriers that they're feeling. So clients with low motivation can certainly achieve high continuous abstinence rates, but I think they need the support of that self-management team, the healthcare team. And irrespective of motivation, all clients should be offered assistance to quit. Any of you that have gone through this Choices and Changes program and a lot of other motivational things have seen this stages of change. This one is specifically for smoking cessation. So if they're in a pre-contemplation stage, it doesn't mean we don't talk to them about it, but we know that that's probably, it's just going to be mentioning it and they're not going to go any farther. Then we have to consider, are they in a stage for contemplation, preparation, action? Are they actually going through a program? And then we can't leave them alone when they're in that maintenance. We have to still be available to handle. Relapses can occur, and we have to be available to handle that. One of the things that I think is interesting from that study on the injection of nicotine, a lot of our smoking cessation programs are involving nicotine replacement therapy. Studies haven't been done completely on it, but if the injection of nicotine can cause the A1C to increase, I think we need to know that we're utilizing nicotine replacement therapy in the most optimal way, that we're not encouraging nicotine replacement therapy to go on and on and on and on. A lot of the programs recommend that no more than 12 weeks could be appropriate or might be appropriate as a length of time for smoking cessation nicotine replacement therapy to be offered to prevent that increase of A1C amongst anybody, whether they have diabetes or not. And that's only a thought that's out there. As I said, there isn't the study. A lot of the nicotine replacement programs, our smoking cessation program, will offer up to 6 months of supply. But I think we need to be really cognizant how we're using it and recognizing there's no sense of giving them the nicotine replacement therapy if they're in pre-contemplation. We're really wasting the product on them at that point. They get frustrated because it didn't work, and then we're only giving them extra nicotine replacement therapy. So part of our role is helping them and being able to recognize what stage of change are they at so that we can optimize in giving the nicotine replacement therapy if that's the route we're going to deal with their smoking habit. The 5 A's, and I think a lot of us are very familiar with these, but it's worth repeating again. Ask, do you smoke? Initiate the conversation. Don't wait for them to say, oh, I'm thinking of stopping smoking. It's important for us to ask that to start with. And advise, encourage them to quit or reduce. Assessing, evaluating their smoking status, and I think I've referred to these at different points, whether it's the nurse asking, whether it's the nurse practitioner or doctor, whether it is the diabetes educator, all of us can do these 5 A's. asking, advising, assessing. Assisting, whether it is sending a referral to somebody who is doing smoking cessation counseling or knowing what is in your community. A lot of health units have a program where they can offer some quitting or reducing counseling, and arranging for follow-up and support, and arranging to be there for the maintenance time of that stages of change as well. Lastly, I've included a lot of names of some tools and scales that can help in assessing what stage of change they're at, and not only helping you recognize as a provider or helping us recognize, but helping the client recognize where they're at as well. Most of these tools that are listed on this page, I did send a copy of them through, and Danielle has put them on the email that you got, that they're available for you to use. They're from a variety of sources, but again, this recommendation has come from the CAMH and the TEACH program. Probably some of those you're more familiar with than others, and I didn't include every one of them. I included the ones that I'm usually using or have used at different times depending on who the person is. Above all, I really want to encourage that smoking is not improving the health of any of our clients, and our clients with diabetes, I'm seeing results. I'm seeing good results. Since we started the program for smoking cessation at our center, we've had about 80 people referred through the program. Probably 60 of those have been willing to actually enter the program, and I would say we're sitting at around 25, 26 people who have stopped smoking. Some of them have had diabetes and some haven't, but we are seeing good health and we are seeing good results in the program. I'm really looking forward to really assessing more, seeing the A1Cs come back in those clients that have stopped smoking. I guess we're going to open it up for questions. As I mentioned to Danielle, and as I said at the beginning, I don't consider myself an expert in this. There could be a lot of help from any of us. So in many ways, if we do have questions, I think that it probably can be opened up for all of us to give our input and experiences and share that. I don't profess to be an expert, so I may not have answers to all the questions. But I will turn it back to you, Danielle, and see if we do have anything.
Hi, everybody. So at the moment, I don't see anything in the chat. Nobody's raised a hand or anything. But what I'll do just for a moment is I'll unmute everyone since we're a small enough group. And then if anybody wants to speak up with a question, they can do so. So I'm unmuting everybody now. So just a moment. So right now, everybody's unmuted. So if anybody has a question for Karen, please feel free to bring it up at the moment, or any comments. And you are unmuted, so if for some reason you're trying to speak and it's not working, please just indicate in the chat that something's going wrong, and I can read your question out loud and troubleshoot at the same time. For example, I believe, Krista, though, if you do have a question, you might have to unmute yourself manually because it seems to be done on your end versus mine. But everybody else should be able to speak. So I guess at the moment that means there's no other questions. Do you have any other final comments or anything, Karen?
Not really. I guess it's just to encourage us to really look at every opportunity we have to help our clients have the best health possible. And to know that nothing in the diabetes and the smoking cessation, we try to look for where we can help improve their chances of prevention.
And if anybody comes up with any questions post-webinar later on, feel free to email me at that self-management email, selfmanagement@kchc.ca, which will be in your reminder emails that you've already received and the follow-up one that you'll get tomorrow. And if we don't know the answer personally as the program coordinator and support facilitator will get in touch with Karen or whoever else we need to get you your answers. So I guess at this point, unless anybody else wants to speak up right now, we'll just say thank you for attending our webinar, and we hope that you enjoyed it, and hopefully see you at the next one, which will be scheduled at the last Thursday of November, and we'll be sending out information on how to register for that in your follow-up emails tomorrow, and usually an invitation on the first week of the month. So thank you, everybody, and have yourselves a great day and a happy Halloween.
Thank you.
Take care.